I'm Dr. Varshini Shankar, and I will be speaking. I'll be taking from where Dr. Siddharth finished. Basically, once we get the information, but we still feel that the examination is pretty much normal, but the child cannot see. So, what is happening? What are the most common conditions which we tend to miss? So usually a careful examination, if you're able to get the information, it gives us subtle clues as to what is happening. A child may have a subtle oculocutaneous albinism, a dilated, good dilatation may show you a microspherophakia. Most of the time there are subtle clues as to what is happening, what is the cause of decrease of vision. But today I'm essentially going to be speaking about a normal eye with or without nystagmus, generally covering CNS conditions including tumors, trauma, cortical vision loss, as well as hereditary fundus dystrophies. So when talking about hereditary diseases of the retina, the best thing is to ask a lot of questions regarding the family history, regarding the presentation, onset, whether the vision loss is progressing, whether it is worse during the day, whether it's worse during the night, and photophobia, like we see in this child who's hardly able to keep her eyes open even for the camera just to take the video. So severe photophobia is always a clue, and it makes us, we can identify a category of the retinal disorder and then proceed from there. So this was a 11-year-old child who had been diagnosed elsewhere to have bilateral optic neuritis. She had been investigated extensively, already treated with IV steroids, and referred because vision was not improving. So the first time I saw her, vision was 636 in both the eyes. Examination essentially normal, disc looking healthy, RNFL normal, VEP okay, maybe little low amplitude, but essentially normal VEP, but vision still what it was. We tapered and stopped the steroids, couldn't really explain the loss of vision, vaguely thinking whether it's functional loss of vision, but keeping under observation. So on one of the subsequent visits, when repeating the OCT, I realized there was a loss of the ganglion cell complex, although the RNFL was normal. So which is when I looked at the macula more closely, you can see there's that mild stippling. And I feel Stargardt's is one of the conditions which is missed so easily in the early stages, because the retina looks nearly normal by the time the vision decreases to maybe 636, 660. However, since we have the fundus autofluorescence photographs now available, it's much more easier to rule out, and the appearance is really characteristic, where it shows a characteristic absence of choroidal fluorescence or the silent choroid. So this is another child, two siblings presenting with a profoundly poor vision since birth, with this roving kind of nystagmus, poor fixation, and high hyperopia. So this constellation of features, there is consanguinity in the parents. Parents are cousins. 2 of the children out of 4 siblings are affected. Very poor vision, poor fixation, roving nystagmus, high hyperopia. I don't think we need any further tests to be done in these patients, because LCA is so diagnostic just by the constellation of features. Fundus generally is normal. This child showed some amount of a bullseye maculopathy. The older one, the younger baby, was completely normal, but this extinguished ERG, unrecordable kind of ERG, is characteristic of these patients. LCA forms about 20% of children in schools for the blind, and a detailed pediatric evaluation as well as renal evaluation need to be done for these children. Coming to congenital stationary night blindness, the term itself is very descriptive of how the patients present. Generally, these are older children. A lot of them may have 6.6 to 6.9 vision, complaining of severe difficulty in night vision. And the patients who have CSNB, of course, is of 2 types, with a normal fundus and abnormal fundus. The normal fundus looks completely normal. It's only on ERG that you can detect the characteristic negative waveform, where the B wave is absent and the A wave is normal, which gives it that negative appearance. In the type 2, both A and B waves are reduced in the scotopic ERG. In CSNP with an abnormal fundus, Oguchi's disease and fundus albipunctatus, have put these photographs because they are not very abnormal. You need to know what that slight green sheen looks like in Oguchi's disease, and in albipunctatus, the spots are in the mid periphery, so not the posterior pole which we are used to looking at in smaller children. So the posterior pole is usually spared, and you have these tiny flecks reaching from the mid periphery to the periphery, which needs to really be looked for. So this is another child, an 8-year-old, with a multiple times visual acuity recorded at about 20 by 40, with this very subtle nystagmus, which pretty much you can see on indirect ophthalmoscopy. But when you look at the retina carefully, you can see the blood vessels running across the FAZ, which gives us a clue to the diagnosis. So this is an isolated foveal hypoplasia where the fovea is underdeveloped with absence of foveal pigmentation and FAZ and continuity of inner retinal layers. OCT is confirmatory, but it's very hard to do an OCT in these children because of the nystagmus. Generally, we are used to seeing foveal hypoplasia associated with aniridia or albinism. So with that overview of hereditary fundus dystrophies, I want to move on to trauma. Trauma is an occasional cause of cortical visual impairment, which can be transient or permanent. Transient CVI following an accidental trauma generally has an extremely good prognosis. But when we look at the constellation of features which are seen in shaken baby syndrome, which is a subdural hematoma of the brain, occult bone fractures, and multiple retinal hemorrhages, then there is a very high probability that this child may have been abused. So when we see retinal hemorrhages in a young child less than 3 years old, we shouldn't be jumping to look at anemia and leukemia and so many other systemic features. Abuse really needs to be at the top of our differential diagnosis. This was a 2-year-old child who came with history of being unable to see following a fall with trauma over the occipital region. The child appeared lethargic. There was no response to direct confrontation, menace reflex, or to optokinetic nystagmus testing. Dilated fundus, and in these young infants, a dilated retinal examination is essential. It showed a mild disc edema with a few dot and blot hemorrhages over the posterior pole. The VEP showed the absence of any response. A diffusion weighted MRI was completely normal. A skeletal survey and a complete pediatric evaluation was done, and the patient was diagnosed to have a post-traumatic CVI. Patient was admitted and observed and started showing response in visual acuity after about 2 days and was normal after 3 days. So in this case, I particularly wanted to present just to highlight that when you see retinal hemorrhages, then you really need to do a detailed systemic evaluation, especially looking for old healed fractures. The next patient is a 7-year-old girl who had a history of wearing spectacles, was patching the left eye 4 hours a day. So when I saw her on a preliminary basis, I thought this is a strabismic amblyopia in the right eye. There was a small RXT 618 in the right eye, 6.9, already patching. So ordered a routine cyclorefraction and did a fundus evaluation. And when I saw the fundus, I thought maybe there was a mild temporal pallor. But in a busy OPD, sometimes you feel that you're seeing either a hyperemia or a pallor in every patient. And in a 7-year-old, no particular reason for that to be there. But just to be on the safer side, I did an OCT. OCT also was, obviously this is false color coded. But there was an RNFL loss more in the right eye than the left eye. So I spoke to the parents and I said, I'm not very comfortable with the scenario, especially since this is the first visit. But I said, it might be better to do an imaging. At which point the parents come out with a history that they've been following elsewhere for the last 1 year, and child has been on patching already, vision has not improved, they've already been advised imaging, and they've just come for a blind second opinion without any of the previous history. So we did the imaging, and this patient had this huge cellular, supracellular lesion with solid and cystic components compressing both the optic nerve as well as the chiasm. And I feel craniopharyngiomas in this age group, especially a younger age group, is very, very easy to miss unless you have a high index of suspicion. The calcification is very easily visible on a CT scan, and they are frequently misdiagnosed or the diagnosis is delayed. Ophthalmic complaints are seen in 96% of patients on presentation. Most of them have some level of optic atrophy, either as a result of initial compression, surgical resection, or radiation therapy. And finally, I'll be ending with psychogenic or functional loss of vision. I personally feel that functional loss of vision is a diagnosis of exclusion, and we need to do a detailed evaluation, a VEP and imaging before we commit to a diagnosis of functional loss of vision. If the visual symptoms are long-standing, if they are progressive, if they are non-fluctuating, then that essentially, over multiple visits, that essentially rules out a functional loss of vision, because children are not capable of keeping up the malingering on a sustained period of time. There are always, all our usual tests which we do, use a plano lens, chest for stereopsis, use red-green glasses. Those usually work in children, and if they aren't, there's usually an organic pathology happening. So I will end with this 13-year-old child who came complaining of multiple systemic complaints as well as ocular complaints. So there is headache, there's dizziness, there's blurring of vision, there's intermittent diplopia, there's stomach pain, there's joint pain, features of UTI, gait instability. Parents had visited every specialist possible, including and had every test done possible, including MRIs, lumbar punctures. Everything was completely normal. From an ocular point of view, the diagnosis was not difficult. The best corrected visual acuity was about 624. Patient had a bilateral abduction limitation binocularly. There was a esotropia, there was a variable pseudomyopia, which was with a lead of accommodation on dynamic retinoscopy, and near normal refraction on cycloplegic refraction. But what was interesting in this child was the multiple systemic features. This is her on the second or third visit, where she couldn't even walk, needed support even to take a few steps. Diagnosed her with spasm of the near reflex and started her on treatment with atropine and bifocals and reassurance, because she'd already been extensively investigated. Everything was normal. Parents, however, were unwilling to believe that. They went to a number of other specialists, went through a whole gamut of tests further. Child had IVMP, followed up with oral steroids, finally went to a psychologist, was started on antidepressants. It took a period of 18 months when the child was on atropine for the spasm to be relieved and for all the systemic features to kind of just disappear. I've had her on follow-up for 5 years now subsequently, and continues thriving, absolutely doing well at school, no subsequent relapses since then. So I would like to conclude by saying we can call it a functional vision loss only after ruling out all organic causes, and a repeated follow-up when the diagnosis is uncertain is required, because at some point we usually get a clue as to what is going on.